valgus and recurvatum. It's a complex situation to handle. Unusual, less than 1% of the patient. We all know pathoanatomy, that stretching of the posterior capsule and PCL, bony collapse on the distal femur and proximal tibia. Problem to be dealt with, large extension gap versus small flexion gap. So in recurvatum, in rheumatoid patient usually comes with the soft tissue laxity with bone loss. In OA patients, primarily bony loss. So rule out progressive neurological conditions. Causes, bony insufficiency of anterior tibia, hypoplastic femoral condyle, compromised collaterals and posterior capsule. In valgus deformity contracted of IT band. So in failed osteo cases, usually anterior slope of the tibia. In neuromuscular disorder, especially progressive disorders. So Mulaji et al. Classified laxity in 3 types. Type 1 coronal, type 2 is coronal and sagittal plain laxity, and type 3 is a global laxity. It's a mediolateral and posterior laxity. We have to evaluate with radiologically joint laxity with the stress views of the X-ray. Surgical technique problem is excessive large extension gap versus small flexion gap. So difficulties in hyperextended knee is significantly mediolateral and stable, abnormal bony structures, reversal of the tibial slope, compromised collaterals. It's a very difficult to balance with the CR or primary knee sometimes. You may end up with the rotating head with extension stop. So we have to plan surgery according to severity of the deformity. So first of all, you should go with the minimal bony cuts, no soft tissue release. So undersized femoral component to increase the flexion gap, and you have to fill the extension gap with the distal femoral augments. Keep thicker poly ready, or if you find in trial that collaterals are not competent, so go ahead with the constraint prosthesis. Sometimes you require proximal transfer of the collateral ligaments. So when surgeon should himself evaluate the patient after anesthesia to assess the deformity and deformity correction, both the things. Here is the case. Thanks Yuvraj providing me these cases. 65-year male, recurvatum more than 30 degree, mediolateral laxity. Valgus was correctable, so we planned for the primary and kept ready for constraint. So same principle, cut less, fill more. So we have to check minimal bony cuts, and the remaining defect we filled with the bone graft and the screws, and we end up with the primary total knee replacement. Another case where 65-year female, rheumatoid, 40 degree valgus and 10 degree correctable. So these are the AP lateral and merchant's view. How patient was walking, type 3 valgus with recurvatum. So here again, we have assessed the deformity correction after anesthesia. That's the most important step for the surgeon to planning accordingly. So minimal bony cuts. So medialize entry to match the femoral canal. So in this case, we end up with the sliding lateral condylar osteotomy to match the flexion extension gap, and that's our trial. In this case, we accepted little laxity in extension as well. That's the immediate post-op AP and lateral view. That's the clinical picture of the patient. These are the post-op, how she was walking after surgery. Another case scenario where patient is having polio, 38-year female, difficulty in walking and severe knee pain, virus of 30 degree. So we planned for the RHK. Right side we did rotating hinge, another side we did rotating hinge with the link because of the spiral canal. Because of narrowing, we end up so many times because of the canal size. So these are the post-op X-ray, AP and lateral views. To summarize my talk, take minimal bony cuts to tighten the extension gap. Keep knee in about 5-degree flexion. Always keep ready with the thicker poly. Use constrained condylar prosthesis whenever you feel that the collaterals are compromised. Beware of progressive neurological disorder. Thanks. I invite all of you for IACon 2026. We are conducting first time in Gujarat, and we are got the opportunity in Ahmedabad. So 22nd we have cadaveric workshop, and 23rd to 25th is the main conference. So behalf of all the organizing committee, I invite, and we have partners, associated partner with AOS, GOA and IOA. Thank you very much.